Brief intervention begins by informing the patient about the meaning of the screening results. This includes a very brief explanation of the total score in relation to the cutoff norms for problem use. This feedback should also reflect the patient's subjective profile. As the patient learns about his or her screening score, the provider helps the patient appreciate why it has evoked concern. Individual motivation has been shown to correspond to a theoretical model of change that identifies stages through which individuals pass in the process of modifying their behavior. The Stages of Change model has 5 different stages: pre-contemplation, contemplation, preparation, action, and maintenance. The Stages of Change does not focus on non-compliance or patient failure. Rather, it appreciates the barriers to change and anticipates relapse. In turn, physicians and patients feel less frustrated and see themselves going through the steps necessary to make change. The Transtheoretical model of change is not a stage model. As seen in this slide, you will notice it is an ongoing process, almost cyclical in nature. The following section outlines patient attitudes or feelings in each stage, as well as an example for each, followed by some suggested activities or needs. It is very important to meet the patient where they are. In other words, speak at a level in which they can understand. The patient will be much more receptive when you, as a good listener, present in an open manner and show concern. Provide your feedback in a non-judgmental manner. The following slides will provide you the tools which will enable you to accomplish this goal. One of the core components of brief intervention is using a technique called motivational interviewing. Developed by William Miller and Stephen Rolnick, it is a client-centered yet goal-directed counseling method aimed to resolve ambivalence about health behavior change by building the patient's intrinsic motivation and strengthening commitment to change. Motivational interviewing is patient-centered. Providers meet the patients where they are. This collaborative style focuses on the patient's goals and values and what they feel confident in their ability to achieve. It is not necessarily what the provider feels is a priority. As a healthcare professional providing SBIRT, your roles are as follows: to identify the use, misuse, and problematic use of alcohol or other drugs via screening using simple direct methods. Another goal is to connect how a patient's alcohol or other drug use or misuse may be related to their health problems and provide feedback. In addition, to advise patients to reduce or abstain from their current consumption patterns through brief intervention. Finally, it is to provide a referral for formal assessment when alcohol or other drug abuse or dependent diagnosis is present. When providing a brief intervention, it is helpful to take the frames approach. In other words, provide feedback about how the patient's alcohol or other drug use is affecting their current or future health status. Letting the patient know that it is their responsibility to change their behavior. You may also give advice based on your medical concerns, and also provide the patient with a menu of options for change. Always use empathy and reinforce the patient's belief in their own ability to change, or self-efficacy. The first step in delivering feedback or brief intervention to a patient is to ask the patient permission to share the results. Then proceed, when given permission, to inform the patient of the meaning of the screening results as you have interpreted them. In addition, it may include a very brief explanation of their total score in relation to the cutoff norms for problem use as listed in the drinker's pyramid. This feedback should also reflect the patient's subjective profile. As the patient learns about his or her screening score, the provider helps the patient appreciate why it has evoked concern. This is an opportunity for the provider to frame the results in the context of a health assessment using the screening results in the same fashion as an elevated clinical laboratory value. As the provider offers this feedback, care must be taken to avoid blame or the implication of scolding. State your conclusion and recommendation clearly. Patients' motivation is increased when their primary care physicians or healthcare providers relate how their alcohol or drug use is impacting their health. By recognizing their alcohol and other drug use and relating it to their health, the patient has a better chance of increasing their motivation to reduce or abstain from their current level of use. The following are examples of integrating advice with health issues. Remember to relate your concerns to the patient's concerns and medical conditions if present. Consider the potential interaction with medication that the patient is now using or you are going to prescribe. Another tool is the drinker's pyramid. Shown on another slide, it illustrates the distribution of persons who achieve various audit scores and where they fall on the drinker's pyramid. Sometimes incorporating the drinker's pyramid in a brief advice session can motivate a patient to consider reducing or abstaining from their current patterns of use. Another important component of providing a brief intervention is remembering that it is the patient's responsibility to change. Your job is to merely plant the seed in order to help the patient consider change. Giving advice without telling what to do. Always ask the patient's permission to discuss their substance use or providing information about their use. Patients need to be active in discussing options, but the ultimate goal is that they make the decision. It is better to suggest than to tell people what to do. Offering advice with permission can be either in the form of making a suggestion or explaining educational information. It's important to note that educational information is factual data that is based on credible information. Facts that relate specifically to the patient's health, substance use, or other information that is shared through the assessment should be presented in a non-threatening way. Advice should be simple and match to the patient's level of understanding and readiness. Another key ingredient to the FRAMES approach is to remember that your patient has options. These options include cutting down on their use, reducing harm associated with their use, quitting all use together, getting help from a specialized provider, or absolutely nothing. It is your responsibility as the provider to give them the menu of options and allow them to make the choice. When a patient has options explained, and they have the opportunity to choose an option of their own free will, the chances that they will follow through are increased. As you provide information about options, it is important to provide the patient education about them. It is equally important to elicit their thoughts about their options. Perhaps one of the most challenging steps of the FRAMES approach is to express empathy. Empathy entails reflective listening. In other words, listening attentively to each statement and reflecting it back in different words so that the patient sees you understand what they are saying. To be empathic is to convey warmth, respect, caring, commitment, and personal interest in the patient. The patient does most of the talking when a safe environment is created. Allow the process to flow, which will permit the patient to move in a new direction. This does require patience, particularly when a patient is resistant. It is imperative that they be allowed the opportunity to talk about their resistance to a non-judgmental person that does not react to their defenses. To succeed in changing, patients must understand that they have the ability to change. This will require self-confidence or self-efficacy in their ability to successfully take steps towards a goal. The steps need to be small. One of the most important roles you have is to foster hope and optimism by reinforcing their ability to be successful. Sometimes this means capitalizing on other changes the patient has made before, reminding them of their previous successes and drawing parallels to their substance use, assuring the patient that he or she can be successful and that you are there to help them. Resistance is normal and should be expected. However, the provider should not revert into being the expert and telling the patient what to do. Rather, listen to what the patient is saying. They are providing you with very valuable information. Here are a few examples that you may encounter and how to respond to these situations. In order to gain some insight into how people change, stop and think about your own behaviors. Pick a behavior that you are ambivalent about changing, whether it be your diet, exercise, or smoking. What stage would you say you fall into? What would it take for you to move into the next phase? For more examples of brief interventions, please click on the following link. The National SBIRT project provides a level of intervention that falls between simple or brief advice and specialty treatment, termed brief treatment. The Pennsylvania SBIRT project refers to this level as intensive intervention. This level of intervention is considered an extension of preventative medicine through risk reduction counseling at the primary care level. It is tailored to meet the patient's readiness to change their behavior and focuses on two elements central to risk reduction. Number one, ambivalence about change, and two, the resolution of barriers to making a change. This level of service is not designed to replace traditional substance abuse treatment. Instead, it provides an opportunity to help at-risk individuals clarify their problematic use, find positive motivation to commit to change, and discover ways to reduce their harmful situation. Some patients produce screening scores that indicate their excessive use is already causing adverse consequences for them. For example, individuals with audit scores in the 16 to 19 range fall into the category of harmful use, where there is acknowledgement of the negative effects of heavy drinking in personal, social, or vocational areas. A brief intervention consisting of 3 to 5 minutes of feedback and simple advice may be inadequate to motivate these patients to change their behavior. At the same time, these individuals may resist the suggestion that they need to seek treatment for a substance use disorder. Often, they may not even meet the placement criteria for treatment, although their excessive or hazardous use still creates a variety of problems. Other non-dependent patients acknowledge their substance use-related problems but have difficulty implementing a plan to change their risky behavior and require assistance with their efforts. The goals of intensive intervention can be adapted to outcomes that correspond to each stage of change. Intervention programs can fail because of the mismatch between the individual's readiness to make changes and the intervention program's focus on action. When people are not ready to commit to a change in their behavior, they ordinarily react to being pressured or pushed into change by becoming resistant and/or defensive, or they may become even more ambivalent about the change and view the message as irrelevant to their personal situation. Efforts to persuade individuals who may be contemplating changing their behavior but aren't yet ready are seldom as effective as efforts to assist them in resolving their ambivalence or strengthen their own internal motivation. In this slide, the goals of intensive intervention in the Pennsylvania SBIRT project are listed. In Pennsylvania, each region approached the delivery of intensive intervention differently. In Allegheny County, the intensive intervention was delivered on-site by the healthcare educator that was employed by the site and properly trained and supervised in providing this level of service. In Bucks County, intensive intervention was delivered as part of an intervention program within the community, overseen by the Bucks County Council on Alcoholism and Drug Dependence. In Philadelphia, a contracting provider agency worked with the Einstein Medical Healthcare System to complete brief treatment with the patients that were referred by the medical provider to the providing agency. Approximately 2 to 5% of the patients that are screened will need a referral to formal drug and alcohol treatment or other specialized treatment providers. However, not all will accept. In Pennsylvania, a group of physicians met in focus groups and expressed their frustration with facilitating access to treatment, the lack of the effective referral system, waiting lists or denial by third-party payers even when the patient was eligible to receive services, and treatment enrollment rules and regulations. Because of this frustration, it's important that when you implement an SBIRT project within any setting to have a connection with the treatment provider system. In order to overcome some of the frustrations with regards to making referrals to specialized treatment providers, Pennsylvania recommends establishing a connection with a substance abuse treatment provider in your area and creating a referral system prior to implementing SBIRT into your daily routine. In Pennsylvania, each county has a single county authority that oversees the substance abuse treatment providers. Establishing this connection with the county was vital in accessing treatment for patients with Medicaid, those that are underinsured, uninsured, or did not have coverage for this specialized treatment. This allowed for easier access to treatment services. In addition, the county can serve as a lead in making referrals to treatment, resources, county funding processes, Act 106 information, and to help cultivate personal relationships between the providers, both medical and specialized treatment. There is support building for screening and brief intervention. The American Medical Association developed codes 99408 and 99409 for screening and brief intervention in the medical community. In addition, 10 states have activated the Center for Medicaid Service Codes for screening and brief intervention. For more information on the subject, we recommend you go to www.insuringsolutions.org. In addition to the AMA and CMS codes, there is continued support building for screening and brief intervention amongst private insurers. Health plans who have committed to paying for screening and brief intervention are listed. In addition, JCO recently called for input into what role, if any, it might play in developing standards for screening and brief intervention in various medical settings. The following is a list of resources or online trainings that are available for implementing SBIRT. On behalf of IRETA and all of the other project partners, we want to thank you for your time for learning more about the Pennsylvania SBIRT initiative. For additional information about implementing SBIRT into your daily practice, please contact IRETA at 412-258-8565.